You're listening to Conferences on Lyme Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is October 2nd, 2023. Our topic today, Allergy Diagnostic Testing and the Practice Parameter. Our presenter is Dr. Julie Wang. She's a professor of pediatrics at the Icahn School of Medicine at Mount Sinai in New York, New York.
So thanks for having me again. My topic for today will be the allergy diagnostic testing and the practice parameter. So actually it's the peanut allergy practice parameter is what I'm going to be focusing on today. So these are my disclosures. They relate to the clinical trials work that I do, not to the peanut diagnosis that we're going to be talking about. I do not.
Hey, Dr. Wang.
Yes.
We're not seeing any advancement of the slide. I'm not sure if you're still on your title.
No, I did advance.
Okay, yeah, sorry.
That is okay. Stop presenting. Let me try that again. Let's see. How do you present? What about this version? No, that's not my, it's the wrong slide deck.
Yeah.
That's not even open on my desktop.
Yeah, we're not seeing anything yet.
Okay. I opened it off of the file already. Do I have to upload it?
You shouldn't have to. It should just be under share, and there's either screen or window. I do believe you can use either of those. At least that's my choices. And
Yeah,
then
it's not giving me. Let's see.
The one option that tends to work best if we don't get it figured out is to log off and log back in. And I don't understand the whys of that, but sometimes that works.
Okay, sorry about that. So log off of Teams. And
Yeah,
back
just
in.
log off of Teams and then
Okay.
link back on, and then we'll see if we can pull it up then. Sorry, gang. And back to save your work off in developer desktop. And I see the PowerPoint kind of not in presenter mode, kind of in working mode. You're muted, by the way, Julie. I don't know if you're.
Oh, sorry. How do I share it, but with the right screen then?
Yeah, so you should be able to, yeah, the presenter mode right there. And that usually.
Yeah, but it opened it onto my first screen. Not the right, not my second screen.
Yeah. Don't know on that end, because usually that's how we would do it, is just hit the.
Yeah, it's just popping up on my first screen.
Are you able to enlarge what you're looking at right now?
Yeah, I can do like this.
Yeah, there you go. So it's not in presenter mode, but we do see the big screen, and I see the multiple little slides on the left tab.
Yeah, let's see, how do I view this? No. View normal. A little bit better?
Yeah. Let's see if you can advance it too.
Can you see?
Yeah, I see your disclosures, objectives.
Okay. All right.
Yeah, we're good.
Sorry.
Thank you. I'm sorry to interrupt you too.
Yeah, so I'm gonna look sideways because I'm looking at my second screen off to the side.
No problem.
Okay. So sorry about that. This is the Allergy Diagnostic Testing practice parameter, focusing on peanut allergy, but I will talk a little bit about some newer stuff at the very, very end. These are my disclosures. They relate to the clinical trials work that I do and not to diagnosis. And I will not present anything that's unapproved or investigative use. So the objectives are to describe the indications for when to test for food allergy and review diagnostics tests available. So just to get us all on the same page, food allergy affects about 8% of children, and it appears to be increasing in prevalence. It can trigger mild to severe allergic reactions, and so there's quite a bit of medical effects that come along with food allergy. The most common food allergens are peanut, milk, egg, tree nuts, shellfish, and fish. And then earlier this year, sesame got added to the top 9, with wheat and soy rounding out the major allergens. So accurate testing for food allergy is important because management entails allergen avoidance and education and label reading, which really affects like many parts of our daily lives. And accidental allergic reactions are possible despite diligent avoidance. And so families need to be prepared with emergency medication and be ready to treat allergic reactions that are unpredictable. So when we're talking about diagnosis of food allergy, we start with the history, followed by supportive testing. And so as in most things in medicine, history is the #1 diagnostic tool that we have to work with. Helpful details in terms of food allergy history include timing of exposure, timing of symptoms after exposure, the character and quality of the symptoms that the patient experiences, as well as response to treatment. Remember, IgE-mediated reactions generally occur quickly within about 2 minutes to 2 hours of exposures, and allergies are reproducible in terms of triggering symptoms. So one who is allergic to milk, let's say, should have issues not only with drinking milk, but with milk-based yogurt, milk-based ice cream, milk-based cheeses, not just reacting to, let's say, the liquid version of milk. We also need to consider epidemiologic risk factors as we're considering whether a person's adverse reaction surrounding ingestion of a food would be likely a food allergy versus another adverse response of the body to a food. So things to consider include environmental exposures, timing of kind of prior oral exposures, as well as other atopic conditions. Important aspects of the history also include thinking about food as a complex of different ingredients. So the primary ingredient may not be the trigger, but maybe it's a lesser ingredient that the family or the patient is not recalling specifically. And because from the history, we have to start thinking about whether the likelihood of allergy, so immune-mediated responses are likely, or is this a non-immune-mediated response? And are we thinking if it's immune-mediated, is it an immediate type IgE process, or is it a non-IgE mediated process? When we're thinking about symptoms of IgE-mediated allergy, there are a variety of symptoms that can be seen affecting the skin, the respiratory system, the cardiovascular system, abdominal or gastrointestinal system, and then neurologic symptoms as well. For kids, the skin and breathing are most common, cardiovascular as well as GI. For adults, cardiovascular symptoms may show up a bit more often than in kids. So in terms of allergy testing, we have 2 main options that we think about in the clinic setting. That's skin prick testing and serum IgE testing. There are pros and cons to each one. What's nice about skin testing is that it's rapid, it's point of care testing. You'll get some results before the patient leaves you that day so that you can start providing some guidance. It does require a trained specialist, so someone who is experienced at administering and reading skin tests, the risk of systemic reactions is quite low, and in generally is a not very expensive test. Serum IgE testing is blood testing. What's nice about, or the benefit of this type of testing, is that it's not affected by antihistamines. So it doesn't matter what medications that the patient was recently taking that day, the previous days. It's also useful for patients who have severe eczema or dermatic graphism, which would make interpretation of skin test results very challenging, or the very uncooperative child, because in general, drawing blood is done much quicker than placing, waiting for development and reading skin test results. There potentially are more side effects depending on, the possibility of side effects. Bruising can happen, perhaps a bit more painful. Some people or some children are much more scared of blood testing than skin tests. But what's nice about blood tests is that multiple allergen tests can be performed with a single venipuncture. So there would be situations where you would choose one versus the other, and or consider using them complementarily. We always also have to remember, as we're thinking about testing, that we want to be thoughtful in what we test for, because there are pitfalls for testing unnecessarily. So if we indiscriminately test children for food allergies, there are potential consequences that the testing process and the results may lead to delayed introduction of specific food allergens, which, as we know with peanut allergy, could potentially lead to higher risk of developing an allergy. If there's a false positive, there's a period of avoidance until we kind of figure out what the true answer is, probably with a food challenge, and that often is not done the same day that you do the skin test or the blood test. So there is going to be a period of time where the family and the child is thinking that they have food allergy and living with the food allergy, and with that create some psychosocial burden. And if it turns out that the child is not allergic, that burden was completely unnecessary to be placed on the family. Also, we have to consider the economic impact of testing unnecessarily with false positive tests, creating the need for additional tests to figure out the true answer. That may require more medical visits. In the interim, as I mentioned, the child is avoiding specific foods and being prepared to treat allergic reactions with epinephrine autoinjectors, for example. And so all of that incurs financial costs for the family that may not be necessary. So I want to turn towards the peanut allergy diagnosis practice parameter, which was published in 2020 in the Journal of Allergy and Clinical Immunology, which will be the focus of this talk. So this was a grade parameter. So just to point out that this is a 2020 practice parameter update, systematic review, and grade analysis. And so what grade means is grading of recommendations, assessment, development, and evaluation. And what this does is it creates an explicit process for evaluating the broad evidence based on specific structured and answerable clinical questions, and allows for a transparent description of how certain we are of the evidence that currently exists. So grade recommendations come in a few different flavors. There's strength attached to it, as well as the direction of the recommendation. So there can be strong recommendations in favor of doing something, or strong recommendations against doing something. And then more moderated would be conditional recommendations in favor or conditional recommendations against. And so these are the definitions for the different strengths and what they would mean. Basically, a strong recommendation would mean that would be something that would be should be done for most patients, whereas a conditional recommendation means that you may make different choices for different patients depending on their unique circumstances. Under the grade process, we also determine the quality of the evidence that exists. So the different studies that contribute are looked at in these analyses, we grade as high, moderate, low, or very low certainty of the evidence. And then, so before we start the grade process, we have to come up with questions. So questions are not determined after the fact, after we look at the data. We determine what the questions are, and then we go into the data to see what the data exists to answer these specific questions. And so for this peanut allergy practice parameter, there were 4 questions that were attempted to be answered. The second question is split into A and B, and then a third question. So question 1 is, should diagnostic testing for peanut allergy be performed in adults and children with a history of suspected peanut allergy who are requesting evaluation? Question number 2 is, in the patient presenting for evaluation of suspected peanut allergy, which of the 3 tests, skin testing, IgE to whole peanut, or IgE to RH2, would provide the highest diagnostic accuracy? Part 2 of question 2 is, in the patient presenting for evaluation of suspected peanut allergy, does testing for peanut components, in addition to skin test or blood test to whole peanut, increase diagnostic accuracy? And then the third question is, in the patient presenting for evaluation of suspected peanut allergy, can the results of the diagnostic test be used to predict severity of a future reaction? So once those questions were established, these were the search criteria. PubMed, Embase, Medline searches were conducted for articles that were published between 1946 and 2018 related to peanut allergy diagnostic testing. And then we basically compared the patients with known or suspected peanut allergy, and then the intervention would be testing. The comparison was a testing for whole peanut IgE versus skin testing, and then the outcome was whether the peanut allergy was proven through an oral food challenge by at least half the study population. So inclusion-exclusion criteria for the different studies are as follows. About 1,300 studies were identified, 127 were selected for full text review, and 89 were selected for data extraction. Meta-analysis was performed, and then a total of 42 studies were included in the final analysis. So looking at question number 1, whether diagnostic testing should be performed in people with a history of suspected peanut allergy who are asking for evaluation. The evidence supports this recommendation, as we suggest in favor of diagnostic testing, either skin test or blood test, for peanut allergy in those where there's a high pretest probability of peanut allergy, or prior to a food challenge for patients with moderate pretest probability of peanut allergy. This is a conditional recommendation, so and there may be some cases where testing is not performed. And of note, the certainty of evidence is very low to support this recommendation. In addition, we suggest against diagnostic testing in patients where there is low or very low pretest probability of allergy. So these were not searchable questions, really, and there was no formal grade assessment performed to come up with these recommendations. And this message really has been around in past practice parameters. This is kind of a lot of the base that we go with for the field of food allergy. So what do we mean by that, basically? So indications for testing, it depends on the history. So if the history of exposure and associated symptoms really points towards IgE-mediated allergy, then that means there's a high pretest probability. Even before testing, you're quite convinced that allergy exists for this person. And in this scenario, testing is generally used to confirm allergy. Now, on the opposite end of the spectrum, if a child has been eating peanut and they've had no issues, then the likelihood that there's allergy is very, very low. So very low pretest probability. And in this situation, no testing is needed because we have enough evidence from history that the person is not, in fact, allergic. Now, it's the gray zones, middle areas that we have to think a little bit harder on. And generally, these are those with no history of ever having eaten peanut. So for a child who's never eaten peanut, but they also have no known risk factors, they have low pretest probability of having peanut allergy. On the other hand, an infant who's never eaten peanut, but who has risk factors of known egg allergy and or severe eczema, then for this case, testing is indicated because of the early introduction guidelines. There are often kids we see who have moderate eczema, so not severe, so not in this category, and or they have other food allergies, so not egg allergy either. Depending on their age, what the other food allergies are, their pretest probability of allergy is variably elevated. And so shared decision makings, talking with the family, understanding what their concerns are, and having them understand the pros and the cons for testing in this scenario would be really important. And then finally, a sibling of a child with peanut allergy, that child, if they themselves have no known risk factors, they are probably not at higher risk for peanut allergy. But depending on, again, how long this child has been avoiding peanut because of that sibling, there may be variations in terms of how elevated the pretest probability of having peanut allergy is in this situation or in this family. So discussing all the different factors with the family is going to be really important when deciding to test or not to test this child. So question number 2 looks at when we think that there is suspected peanut allergy, what test should we use if we decided that testing is what we want to do? And so the evidence, and this underwent the grade evaluation process, the recommendation is that we suggest in favor of testing IgE to RH2 in a patient suspected with peanut allergy if you have only one test to pick, because RH2 would provide the best diagnostic accuracy as determined by virtue of more optimal positive and negative likelihood ratios. But it's important to note that while IgE to RH2 has the greatest specificity, sensitivity is lower than skin tests and blood tests, and I'll show you some of that data in the next slides. So in a patient with high prior probability or pretest probability, the clinician may use the variety of tests to confirm the diagnosis of peanut allergy. Again, certainty of evidence for this recommendation is low. And then part B of this question was in that patient suspected of peanut allergy, does testing to components add to, if you've already done skin testing and or blood testing to whole peanut, does it increase the diagnostic accuracy? And the evidence suggests that we suggest against component testing in addition to the skin test or whole peanut IgE to increase diagnostic accuracy. Again, remember, this is the data up until the point that we had analyzed the literature for this practice parameter. Okay, so to give you some of the data, this is the sensitivity and specificity for peanut skin testing and blood testing. Both tests have high sensitivity but low specificity. So what that means is that if you test the person with test for peanut allergy with skin testing or blood testing, high likelihood you're going to catch the true allergics as well as some extra people because the specificity is low. And so what this means is a positive test in isolation is not diagnostic for food allergy. So again, a positive test means that you'll catch the people with real allergy, but then some extra people. And so you're going to have false positive tests. And that's why the general recommendation is that panel testing and broad screening should not be done without a supporting history, because you're going to label extra people with peanut allergy than who in fact do have peanut allergy. On the flip side is that a negative test essentially excludes the presence of IgE-mediated allergy to that food. So where a negative test is quite helpful. Now, using the data, we also analyze likelihood ratios. And so likelihood ratios are used to look at two things or assess two things. One, the potential utility of a particular diagnostic test and how likely that a patient has that condition. And so likelihood ratios are basically a ratio of the probability that a test result is correct to the probability that the test result is incorrect. So the positive likelihood ratio is defined as sensitivity over 1 minus specificity, whereas a negative likelihood ratio is 1 minus sensitivity divided by the specificity. And so what we do is we take the pretest probability that a person has a disease based on the history that we've collected, and then we look at the likelihood ratio for that test result, which again is based on the sensitivity and the specificity. And combined, that gives you the post-test probability that the person has a disease. So we use Fagan nomograms to help us kind of think about this a bit easier. So what this does is estimates how much the diagnostic test result changes the probability that a patient has a disease. So if the pretest probability, we thought that the patient had high or low probability of the disease, by having either a positive test, how much that changes the likelihood that the patient has the disease, or a negative test, it changes the likelihood that the patient doesn't have the disease. So these are the Fagan nomograms for the skin tests for peanut at the positive cutoff of 3 millimeters. And so what we have are three categories: those patients with low pretest probability of allergy, those with high pretest probability, and then a middle ground of the moderate pretest probability individuals. And so for those who we didn't believe that there was peanut allergy based on history, you'll see that the testing really doesn't change your the chances very much. And so testing very likely doesn't make a difference in this scenario. For those patients with high pretest probability, we really think that the patient has peanut allergy. A positive test changes things a little bit. It increases from like 70 to 80% probability that the patient has allergy, so increases a little bit, but it's not definitive that we needed the test to know the answer. It's this middle ground that we often need the most help. And while food challenge is the ultimate diagnostic tool, that is time and resource intensive. And so we often do want diagnostic tests to help us lean more in one direction or the other of likely allergy yes or likely allergy no. And so in this scenario, you can see that the red is if there is a positive test, it increases from like 30 to about 40 to 50% likelihood that the patient does have an allergy, whereas the negative test actually drops the likelihood that there is allergy significantly from 30% down to 2%. So you can confidently say that that person does not have a food allergy. The same thing was done for peanut IgE with a cutoff of detectability at 0.35. So again, those by history we didn't think has a peanut allergy. The testing's not going to change our minds about that. And then for those with a high likelihood of peanut allergy based on history, a test result isn't going to change our minds significantly in that regard as well. For this middle ground, it changes things a little bit. So for the practical question that I think we all have is, well, in the clinic, which one is better? Do we do the skin test or do we do the blood test? And the evidence really shows that there's no discernible advantage of one test over the other in terms of sensitivity or the specificity. There was not data available that really looked at simultaneous or tandem or reflexive use of both tests, meaning that they rigorously looked at what if we use a combination of the two or test one test first and then go on to the second test. And on the flip side, there's no data showing that both tests together was disadvantageous. So ultimately, the choice is these are conditional recommendations. So it's subject to the preference of the clinician and the family. So shared decision making about testing and which test to use is going to be important. Now, we know that we can do testing to individual peanut proteins because component testing is available for peanut. And this chart lays out the different peanut proteins that are have been identified and the ones that can be tested on by component testing. H1, 2, and 3 are the seed storage proteins. So they are stable with heating and they are considered the major allergens for peanut. RH6 is a homolog of RH2, and then RH8 is a BEP1 homolog that is heat labile. And so people who have pollen allergies, so pollen food syndrome, may test positive for peanut via RH8 if they are birch pollen sensitized. Also point out RH9 is a lipid transfer protein. It's also a stable protein associated with, can be associated with severe symptoms as well as oral symptoms, and this predominates in the Mediterranean area of the world. So comparing RH2 IgE with skin test and IgE to whole peanuts, we see that the sensitivity is a little bit lower, but the specificity is much higher. And as a result, the test for RH2 is going to has a much higher positive likelihood ratio, and it's going to swing our percentages much greater than the skin test and the blood test. And so we can see that here in these phagonomograms for the RH2 IgE with the cutoff of 0.35. So again, at the extremes, they're going to make a little bit of a difference, but we probably knew the answer before testing was done. But in this moderate pretest probability group, having a detectable RH2 can raise your pretest probability from 30% to a much more convincing 70%. So these are the current knowledge gaps in relation to component testing. We need more data still to truly understand the value of testing for RH2 IgE reflexively if the whole peanut IgE is already detectable. We would benefit from having more data about the performance of other peanut components such as RH6 and RH8 because often for component testing, you get the whole spectrum of different peanut proteins. You don't just get the RH2 IgE level. And so more data is going to be needed to help us interpret kind of the complex of if you have some positivity to the different peanut proteins. And then of note, history ultimately is number one. And so it is possible to have a history of convincing allergy and in fact real peanut allergy despite having an undetectable IgE to RH2. So that's always important to keep in the back of your minds that if testing doesn't match what you know in history, more evaluation is going to be needed to help find the true answer. Don't let the testing in isolation drive all your decision making. So now question number 3 looked at severity because a lot of patients, besides wanting to know whether the child does or does not have peanut allergy, their next question is, well, if my child does have a peanut allergy, are they going to have a severe reaction if they accidentally eat peanut? So recommendation 3 is that we suggest against using any of these test results to determine the severity of a reaction. There is a big knowledge gap in this area, so more work needs to be done to identify predictors of what type of reaction or what type of phenotype a peanut allergic person has. But in looking at the data about severity, we see that the tests are poor predictors of future reaction severity. And based on the data available, the tests were looked at for skin tests at 10 millimeters, the whole peanut IgE level at 50 kilounits, and then an ARH2 IgE at 2 kilounits. So the whole peanut IgE has very low sensitivity but high specificity, whereas ARH2 at a level of 2 has a high sensitivity but low specificity. So with a very high peanut IgE level, if it's very positive, that can help, but you're going to miss a lot of people who potentially can have severe future reactions. And then for ARH2, positive doesn't necessarily indicate that that patient will have severe reactions in the future. So I had mentioned that under the grade framework, we have to look at the data and determine, the quality of the evidence there. And part of the assessment is a risk of bias. So study limitations, every study is kind of designed differently and it has different limitations. And we see that overall, a lot of the studies that were identified and incorporated into the assessment for this practice parameter fell into the mild green or moderate risk of bias yellow. These assessments were mainly due to the small sample sizes that were chosen from large clinical populations without very clear indications as to how the patients were picked. Often they were not random patients, nor were they consecutive patients within the clinical population. Additional risks of bias were because of food challenge and the diagnostic test being performed at different times. So there could be a gap of many months between the test result and the food challenge, such that there's uncertainty as to whether the test results matched up very closely with the food challenge outcome. Also, sensitivity analysis removing the study is at risk for bias for both patient selection and flow timing of tests revealed no significant differences in the estimates. So this is a summary of the recommendations for the different questions that were answered in this practice parameter. But the key take-home points are that positive tests, remember, detect sensitization, so whether there's IgE present or not, but does not always equate to allergy. These are not the same concepts. When there is very high or very low pretest probability based on the history, then the choice of test really doesn't matter because the skin test or the blood test will not move that percentage chance of allergy by much. It's that middle zone when there's indeterminate or moderate pretest probability, then ARH2 IgE offers the lowest rates of false positive tests. Important to remember, because of the sensitivity specificity characteristics of these tests, that food panels should not be done. And kind of adding on, since you happen to be doing allergy testing, adding on a peanut test, if the history does not indicate it, is not a good idea. And again, as we consider tests, we always want to think about not only the potential benefits of testing, but also the potential harms that can result if there are false positive test results. Because remember, it's very hard to delabel. And in the interim, while you're trying to delabel somebody for having a peanut allergy, there are significant health and economic impacts that are affecting the patient and the family during that time. So this practice parameter focused on peanut allergy diagnosis, but obviously there are multiple other food allergens that are out there that can be tested for. So I just wanted to point out a review from about 2 years ago that kind of nicely summarized diagnostic cutoffs. These cutoffs have not undergone the grade assessment. So remember that sensitivity, specificity, likelihood ratios are all going to be variable by food, and it depends on the studies that are available for each of these foods. And then similarly, there have been components for other foods that are commercially available now, and there is quite a variation in terms of sensitivity, specificity of components at different cutoff levels for the different foods. And so while we have a better understanding of how to look at peanut components, still much more needs to be done before we have a really good sense of how to use the other components in our daily practice. And then I want to move to kind of newer testing. Epitope testing has been looked at to try to improve diagnostic accuracy of testing. So we have started with IgE testing to a mixture of whole peanut protein, so a mixture of different proteins, and then component testing, which is IgE to the different peanut proteins. And now this epitope mapping is looking at where on the specific peanut proteins the IgE antibodies are binding to, and kind of what additional data that can provide if we know exactly where the IgEs are binding. And so the bead-based epitope assay is now CLIA approved as a clinical reference laboratory test in the US. In most states, I will say that in New York it is not yet available, but in many other states in the US this is an available test, so something that if you haven't encountered yet, patients may be asking about it. So there were early studies of epitope analysis using peptide microarray that found that how tightly the IgE bound to the peanut proteins and the epitope diversity, meaning how many areas of the peanut protein the IgE binds to, can correlate with persistence and severity of the allergy. Particularly for milk allergy, and there were also correlations with reaction severity at food challenge and eliciting doses, and those studies were done for peanut allergy. So now what's commercially available is a speed-based epitope assay, which is a high throughput multiplex assay that can measure IgE and IgG4 to over 90 sequential epitopes using microliter quantities of serum or plasma. This assay, so BBEA, for peanut was validated using two large cohorts from COFAR2 and the POISE, both were clinical trials, showing that the BBEA test for peanut has high sensitivity, high specificity, high positive predictive value, and high negative predictive value, all in the over 90%. And that this assay can accurately predict food challenge eliciting dose, or the threshold at which a person would react with peanut exposure. So what this test can tell is whether a person is allergic or not allergic to peanut. And then if they are allergic, what their threshold would be. Level 1, meaning reacting to small doses. Level 2, moderate doses will trigger symptoms, and then level 3, meaning higher thresholds higher degree of exposure is needed to trigger symptoms. So this is a sample test result printout, but focusing on up here, this is basically the graph showing the different thresholds. So level 1, level 2, level 3, and as an example, around 300 milligrams is what we say equals to 1 peanut. So we'll look at this bar, which is 444 milligrams of peanut protein. If you're level 1, very few people are able to tolerate this dose. At level 2, about 30-something% are able to tolerate this dose. And for higher threshold people, 70-something% of individuals are able to tolerate about a peanut worth. So this test can start distinguishing between phenotypes of peanut allergy. Here is a summary of the different lab tests available. So we talked about IgE, the whole allergens. We talked about component testing. I just mentioned epitope analysis. Basophil activation tests and mast cell activation tests are also under investigation. A few words about the bat. CD63 is the most commonly used activation marker for bats. Some studies use CD203C. The diagnostic performance does vary by food, and the bat, based on the studies thus far, seem to have high sensitivity, high positive predictive, and high negative predictive values. And there's data suggesting that bat might predict severity and thresholds of clinical reactivities at food challenges, and that might even be able to serve as a biomarker for desensitization and sustained unresponsiveness or remission for those on immunotherapy. But it's important to note some of the limitations of that, which is kind of need to be addressed before widespread use can be done, is that it is quite labor intensive, requires specific expertise, and there's quite a bit of variability in terms of protocols and interpretation. One key is that BAT needs to be performed within 24 hours of sample collection, and so that can pose a lot of logistical and access challenges. So these limitations need to be overcome before I think widespread use of availability of this test. Mast cell activation also is being looked at right now. More work it needs to be done. This has lower sensitivity compared to BAT and high specificity, but some of the technical issues are not problematic for mast cell activation tests. And then this is a summary of the knowledge gaps and future research needs. And you can see, there's certainly more to learn even for the tests that we have routinely in our clinic these days. But there's still work to be done, and hopefully we'll have more diagnostic tests available to us in the coming years to help really tease apart who does and who does not have food allergy. So with that, I will open this up to questions.
Hi, I was Ishan. I was one of the Children's Mercy Allergy Fellows. I have a quick question regarding the peanut bead-based epitope assay. Do you have any idea how expensive that ends up being for patients in terms of cost?
So it can be variable. I think it's a couple hundred, but because it's not used in New York, I don't know what the current prices are. It has not been CLIA certified in New York yet, New York State.
Gotcha. Do you know if it's certified in most of the other states?
Most other states, yes, but I don't have the breakdown of exactly which ones do and which ones don't.
Gotcha. Thank you.
I have a question, Dr. Wang.
Hi.
Thank you for joining us. By the way, Jay Portnoy here. I've been seeing a whole bunch of patients. I think in the last 3 weeks, I've seen 6 patients between 5 and 11 months of age. Parents feed them peanut for the first time and they get a rash on their face, and that's it. Mm-hmm. And a month later, it takes a month to get in to see me, but they come in and they want to know what to do. And I've been telling them, we know that it causes a rash, nothing more. Your child is sensitized, but it's not life-threatening. I've encouraged them to continue feeding the peanut and not worry about the rash. And so far, all 6 of them have been doing that successfully. I was just wondering what you think about this conundrum, because we're starting to see a large number of very young infants with just rash and nothing else. So we know they're not having anaphylaxis. I give them an EpiPen anyway, so they feel comfortable doing it. But I mean, what do you think about that?
Yeah, no, I see that often as well, and not just with peanut. I've seen it with egg, with milk, and so I think this is a great question and clearly clinically relevant, and your outcome is the same as mine, that many actually do quite well with reintroduction and just good guidance. And so what I generally, I go through the basic questions of, is it around the mouth? Was the child self-feeding? Was the child not self-feeding? Because if they were self-feeding, then, contact is much more likely. Whereas if it was a spoon directly in the mouth and never touched anything else, maybe I'd think a little bit harder on that. I talk to families about and then I'd look at the child's risk factors. Do we know whether the child has eczema or not eczema, what severity of eczema they had, how they did with other solid foods. If really there are no risk factors, I talk to the families to say, many infants have very sensitive skin. It was where you were feeding. You didn't see it anywhere else. Most children do not have food allergy. In fact, majority, we talk about 8% with food allergy, 1 to 2% with peanut allergy. That means 90+% do not have food allergy in the world. So,
most of these kids that I see have eczema. It's being fed not just on contact. Sometimes the hives happen on their chest or their back or someplace slightly distant from where the food is going in. None of them are having reactions. I've decided not to do testing on any of them because if the test is elevated, the parents will get frightened and stop feeding the peanut. I always give them a choice. I tell them that most allergists would instruct you to avoid peanut and carry epinephrine, but you have this option of continuing to feed it, and I will just watch you closely. The important thing is to see them soon afterwards, like every 2 weeks for a few weeks till they feel comfortable doing this.
Yeah, absolutely. So the key word is shared decision making. The family has to have a good understanding of why I'm suggesting what I'm suggesting. I need to know that they feel comfortable, because the worst case scenario is I'm suggesting reintroduction and no testing, let's say, and the family is not on board. And then they go out and find somebody else who's willing to test. That, is not helpful at all.
Yeah, you don't want to do that.
Exactly. So it sometimes is a lengthy conversation, but I think it's an important one because it'll save the family, much more heartache later. And it's shared decision making. So if the family really is just very uncomfortable with refeeding, then we will pursue tests or bring them in very quickly to do food challenges. Again, in that scenario, they understand clearly the potential downsides of false positive tests and, that period of living as an allergic person. But also in our practice, we prioritize these babies to bring them in so that there isn't a several month gap. If we have testing that's a little uncertain, like we went down the road of testing because that was what the family, conversation ended up with, we're quick to bring them into a food challenge and say, okay, well, now we need to do this next step. You understood that there were multiple steps to really tease out the final answer.
Yep, obviously a lot more work needs to be done, but we need to answer these important clinical questions quickly and not wait for the definitive answer to come out. Right. Thank you for your presentation.
Yeah, you're welcome. And I think what you also bring up is very important. Is a lot of our diagnostics is in talking with the family, not just hearing that, oh, something happened time-wise near eating something. Let's just test and then see what happens. Because that's a huge service to our families.
Yeah, it's kind of a shifting paradigm to say, okay, if you're only a cutaneous reactor, do you say continue with eating it with the idea that we'll build tolerance, or what percent of people have a risk for more than cutaneous with future exposure?
Right. So that's why these newer tests hopefully will give us better tools to help make those decisions. But as I think Ishan mentions, cost is an important factor as well. And so, when we're thinking about doing tests, we also shouldn't just willy-nilly throw on every single test just for the heck of it because we can. We have to think of the risks and the benefits of false positives, false negatives, the economic impact. We don't want to stick families with the bill for an expensive test if that test was never going to change what we really thought the answer was. Like if the child doesn't really have peanut allergy and we can, have a lot of evidence surrounding that peanut allergy is very low on the differential, then slapping on an expensive test is not going to help the situation.
Exactly. Yep. All right. Well, time for one more question from the group. Okay, all's quiet. So, Dr. Wang, thanks again for being present in your conversation today on diagnostic testing. Appreciate that you're part of COLA once again. And we'll have this edited and uploaded to our COLA on YouTube within a few weeks.
All right. Thanks for having me.
Okay, thank
Have a
you.
good day.
Appreciate it. Bye.